Hey guys, and in this video covering the content of the OCR A-Level A2 Psychology specification, we're going to talk about a study from the health and clinical option, and that is about fear arousal and its ability to improve or decrease people's adherence to medical regimes. Now, I always start these videos off with precursors that I know not everyone's interested in psychology, and certainly not everyone's sitting this A-level specification, but I do these videos because telling you guys about it helps me to learn, and particularly when it comes close to exam time, there will be people who I hope will find these videos helpful, and it's just interesting to learn in general, expand horizons a bit and sort of learn more information. So that's what we're going to talk about. In the health videos, which obviously this is one of them, like I said a minute ago, I also had a special precursor that I'm not doing this in class. My school, you choose 2 options out of the 4, and my school does crime and sport, but I'm choosing to do crime and health. So I'm doing health in my own time with no support from teaching staff. So if I miss anything out that's critical, and you're also doing this in the exam, then sorry, but use these videos at your own risk, and I hope they're helpful. I've got some notes, so I'm going to be glancing to the left to look at them. We'll talk about this. So, like I said, what we're talking about now is the effects of fear arousal on whether people will adhere to medical regimes or not. And in the case of this study, Janice and Vesbeck, 1953, what they did was they asked students from an American high school, a whole class worth of them. They gave them a lecture. They split them into groups. 2 of the groups got a lecture on dental hygiene, and one group was a control group and got a lecture on the human eye. But what they did was they aroused their fear in different ways. So what one group had strong fear arousal, so they had groups. They were shown pictures of people with bad gum disease, and the lecturer was quoted saying things such as, "This could happen to you." So high fear arousal, but the same amount of information as group 2, who had low fear arousal, and the participants were aged between 14 and 15.11 years, which according to this is 9th grade. I'm not acquainted with the American educational system, so you guys can correct me on that if I'm wrong. But so it was an entire class of high school participants, I'm guessing from one high school. So you've got, obviously, they're all students, so they may not be representative of people who aren't students. Students are kind of a special breed. You used to taking in more information and maybe taking it in a different way. So from an evaluation perspective, that might have a strong bearing on the findings of this particular study. So every group got a 15-minute lecture, and it was an independent measures design. So you've got the usual problems with independent measures: high amount of participant variables, so possibly low reliability because each participant brings different complications and different attitudes to the table. So each lecture was 15 minutes, and it was illustrated with photographs. Before a week before the study, participants were asked to fill in a questionnaire about their dental hygiene practices. So self-report questionnaire. You've got the usual social desirability problems. And when it comes to health and adherence to health regimes, that is a very strong problem because people are very likely to say that they use more health or take more health advice than they actually do to make themselves look good. So I think I said 2 experimental groups and 1 control group who had a lecture on the human eye, but reading over the notes, it was actually 3 control groups. There was high, medium, and no fear arousal, just informational, and then there was the group that had a lecture on the human eye, and we'll talk about that in a minute because there's an interesting finding on that suggests that was a particularly good control group to use. But yeah, a week before the lecture, they were asked to fill in a questionnaire about how they adhered to medical regimes or dental regimes. Sorry, they were given these 15-minute lecture according to whatever condition they were in, whether that be the control group, the high fear arousal group, the moderate fear arousal group, or the no fear arousal, just information, but still about dental regimes. Immediately after the lecture, they were given a questionnaire asking them sort of qualitative questions about how they felt about the lecture, how they viewed it positively or negatively, and there's some interesting results regarding that. And then 1 week after that, they were given another question asking about how their dental practices had changed according to the lecture. So obviously, there's again some social desirability problems there. If someone is giving a lecture on dental hygiene, you might want to say you'd improve after the lecture because you don't want to look ungrateful or like you're not involved. So some of them there might be some social desirability problems there, but again, I said about it being a particularly good control group to use because we'll talk about that in a minute. So they've had a 15-minute lecture and basically three questionnaires. So the measures were basically 3 questionnaires: a post-lecture questionnaire, a immediately after lecture questionnaire, and a 1 week later questionnaire. Okay, let's get to the results. According to this, the amount of medical, the amount of dental knowledge was equal between the group before the lectures. So that would suggest that they were a well-matched group, and that any changes could be attributed to the independent variable, i.e. the amount of fear arousal, rather than any confounding variables, as we'll talk about later. Particularly with independent measures, there's always confounding variables, but that finding would suggest that the independent variable was causing the changes in the dependent variable, because to start off with they were all the same. And interestingly, remember I said in the intermediate questionnaire that they'd had as soon as they came out of the lecture. The people in the strong fear arousal group, so that was the one that had phrases like "this could happen to you," that was viewed more positively than the other two experimental groups. Now, I want to editorialise a bit here and give a bit of personal opinion in the fact that I don't personally see why that would be, and we're going to talk about later in the conclusions. They even acknowledge that there's some contradictions to this study, so the generalisability of it might be there. The fact that people responded better to the higher fear arousal, I find that difficult to agree with, quite frankly. But so we've been up to qualitative data so far, information-rich data that's difficult to analyse. But now we get to some objective, or at least some quantitative measures that are easy to compare, so we can see a direct comparison. The strong fear arousal group, in between the two questionnaires, the before lecture and 1 week after lecture questionnaires, showed a net increase of 8% on adherence to medical regimes. So the example it's got here, one of the things it asked was, do you brush your teeth for the recommended 3 minutes? And there was an 8% increase on people who showed conformity to the medical advice after being in the fear arousal lecture. Obviously, in the independent measure design, participant variables, so it could have been that everyone in the fear arousal group was just predisposed to change their behaviour anyway, and it was getting the information that improved them, not the amount of fear arousal. So there's not entire control of the independent variable, but 8% increase in conformity for the fear arousal group. The moderate group, so there's who are some fear arousal but not much, the increase was 22% on the same measures. The increase in the minimal fear arousal group was 36%. So that would suggest that if you use some fear arousal but you don't patronise them, you mostly give them information to make up their own mind, that would suggest that that's the better approach to trying to convince people to adopt health behaviours. 8% increase versus 22 versus 36, and that's that's high, moderate and low respectively. And what I was saying earlier about the control group being well matched, there was a 0% change in the control groups, so you might expect some social desirability there, people giving different answers because they think, well, we've been asked this questionnaire once, we're being asked it again, so why would they do that unless it was wrong? That would suggest that wasn't a problem in this study, because those participants didn't have anything to do with the dental. They had a lecture on the human eye, so that you would expect there to be a 0% change, because they've not gained any more information that's relevant to the questionnaire, and there was indeed a 0% change. So that would suggest that the variables are well controlled in spite of the reliability sort of participant variable control issues that I discussed earlier. So from those findings, it was concluded that fear arousal is indeed a good method of improving health behaviours, but that low fear arousal is the best, and where that was say it was 8% for strong, 27% for moderate, and 36% for low. So that again, that would suggest that low fear arousal is the best way of doing it. But then it has to be right for the respected audience. So if you told a group of, if you said to a group of 50-year-olds, your teeth will all fall out in the same way that you said it to a group of 14 or 15-year-olds, they probably wouldn't respond the same way. They'd probably just feel a bit patronised. So even they acknowledge in a paper that there's some ethnocentrism issues here, and kind of specific age issues, and to that end, says here, so some studies have directly contradicted what Fishbeck found, not with the same sample but with different samples. And Leventhal et al. 1967 did it on smokers. So maybe a different set of attitude will lead to smoking and lead to not adhering to dental regimes. So maybe that's another confounding variable between those studies. But again, Leventhal 1967 did it on smokers and found that high fear arousal was more effective than either of them. So Fishbeck found that low fear arousal was most effective, but Leatherman found the complete opposite, that high fear arousal was most effective. Obviously there are two completely different studies on two completely different samples, but that is an interesting thing from an evaluation perspective, that casts doubt on the generalizability of these results. But there does seem to be a general consensus that having some level of fear arousal does indeed increase your adherence to a medical regime. So I thought that was interesting. Anyway guys, that's it. We normally do a separate section on evaluation issues, but we've covered lots of evaluation issues there. We've got ethnocentrism and low reliability being the main ones. We've got social desirability because people's adherence was gained by self-report. We've got reductionism, which I didn't cover. It might not be the fear arousal that's counting. That it might not just be the fear arousal. That might not be the only thing that's causing the change. So it might be reduction, because it's only looking at one factor. And that's that, guys. Anyway, thanks for watching this video, and I'll see you in the next video. Bye bye.